Welcome to the ACO Show, a podcast about the American healthcare system and some of the people who are trying to make it better. I'm Josh Israel, joined by my co-host, Sean Cavanaugh. Hi, Sean.
Hi, Josh.
Our guest today was Margaret or Peggy O'Kane, who founded and ran the NCQA for almost 35 years. So, Sean, what did we learn today? What is the NCQA?
That's a great question because I think people think they know and often get it wrong. But at one level, NCQA develops quality measures by which to measure how health plans or individual practitioners are performing. Those measures are frequently used by employers through something called HEDIS, but also by CMS in its quality measurement programs, most notably in the Medicare Advantage STARS program.
Yeah, I was glad we could talk about how the program got started and how it does super important things, but also in some ways has gotten out of hand.
Yeah, I mean, Peggy has a long arc of a career from when the concept of measuring quality was sort of the Wild West. It wasn't universally accepted that it should be measured, could be measured, and those who were measuring it were doing it very different ways. Things have improved in many respects, but as you say, I think there's some backlash now that there's maybe too much burden to practitioners and others in reporting these quality measures.
Yep. Let's hear what Peggy has to say. We are now joined by Peggy O'Kane, who's the CEO, founder, and president of the National Committee for Quality Assurance, otherwise known as NCQA. Welcome, Peggy.
Thanks. I'm really happy to be here. Really appreciate the opportunity.
You have had a 35-year run at NCQA. You actually started it. What made you start an organization like this?
Well, it's a long story. How far back do you want me to go?
Go to the start.
All right. So I was a French major in college. I actually fell into becoming a respiratory therapist. And it gave me an incredible view of what was going on in quality in hospitals. And I found it to be pretty shocking and kind of, would come home and talk to my husband and say, you can't believe what, the things that go on here. And he said, well, why don't you work on quality? And I thought, who would want to hear from me about quality? So what really made the difference was getting a job with Group Health Association of America, which was then in a moment when it was moving beyond group and staff model HMOs to the HMO model more broadly adopted by employers. Employers were persuaded that they needed value-based payment in order to get the healthcare system to work right. And this was like in the late 80s. So I was there. I was really persuaded about the model being right. It was this moment when Paul Elwood's evangelizing about HMOs was really coming together. So lots of really good timing for that.
Peggy, you're gaining all this experience, very practical and academic as well. You've got an idea that quality is not in great shape. How do you make the leap, though, to starting an organization? Where do you get the funding? How did you get the recognition that you were the one to do this?
Yeah, well, I would say, Sean, it was a lot of timing was really on our side. The employers, Paul Elwood had been an evangelist for HMOs, which would be held accountable for outcomes, both financial and quality. So he had stirred up employers and major insurance companies, which had only done indemnity before, were creating HMOs. And so there was this massive movement of large employers who, by the way, were fully insured at the time, to HMOs. And they wanted to make sure that they were offering high quality options to their employees. So they were all out there with their consultants doing their own thing. It was like a complete Tower of Babel for quality measures. You couldn't compare one with another. So we went to them and said, let us do this. You give us the authority to do it. You require it of your contractors, and we will do a really good job. You'll be able to benchmark. And by the way, we can kind of create a roadmap for what a good HMO is.
Peggy, how would you, or how do you describe NCQA? What's your sort of elevator pitch on what it is and what it does? And do you ever wish that the National Quality Foundation, or NQF, had to take a different name so people didn't confuse the two all the time?
I'm not going to go down that road, but I could say it was not an accident that it happened. We're a quality organization that tries to drive better outcomes and to really kind of discriminate between high quality and low quality, not only in the health plan space, but as you know, in the patient-centered medical home space. And we really do aspire to do ACOs if we ever get there.
Did you ever think when you started this that you would become the brand name, in the sense that there's Xerox and Kleenex? A lot of people think that HEDIS measures, all quality measures are HEDIS measures, but they're not. Those are the quality measures that your organization has created. And there's others, but those are the ones that people talk about as if it's the standard.
Yeah, well, it has its upside and its downside, because I think while I'm really proud that we kind of put quality measures on the map, that we created a national system where quality became a business issue. That's kind of a crude way of saying it, but I'm kind of echoing a CEO who said to me in the early days, quality is not a business issue for us. So it has its good and its bad points. I think one of the things that I feel walking away now at the end of this long career is we really need to get those people who are delivering the care to be engaged and to be kind of champions of quality, not to feel that this is something that's inflicted on them and that's done often unfairly. And I agree with many of their critiques. So I'm hoping that my successor, Dr. Vivek Garg, can move us in that direction. We're already trying to get there. But
Peggy, you mentioned NCQA develops a variety of measures, but let's stick with health plans for a second, because that's where your roots are deepest. But it's also where I became most familiar with you through my work at CMS. Can you describe what exactly NCQA's role is in quality measurement, for example, in the Medicare Advantage STARS program?
yeah, well, a number of the STARS measures are our measures. There are other measures that are kind of more like customer service measures. But we have been kind of the heart of the STARS program. In our vision, no practitioner would have to touch quality measures. They would fall out of their digital delivery of care, and then they would see their results in real time, not a year later. And they would reflect the reality that they're practicing in. The other thing that I want to say is the universal foundation idea that came out of CMS, that although you measure at different levels of the system, like the individual doctor, which I don't particularly agree with, but the ACO, the plan, the underlying logic of those measures should be the same. So you don't want a situation, which we do have today, where I'm a doctor. I'm trying to choose whether I want to do the doctor measure, the ACO measure, or the plan measure, and the plan's holding us accountable for that. So there's a lot of work to do.
I want to clarify for our listeners, Peggy, you referred to the Universal Foundation. That's a concept that CMS developed a few years ago to try to create common measures across its various programs. As you said, there's work to be done. One of our concerns representing primary care physicians is we were hoping a universal foundation would lead to fewer measures. Unfortunately, that hasn't been the case.
That wasn't the goal. I do think this business about measuring individual doctors is really interesting, because I think people do want to know, is my doctor the best doctor, right? That's the way it's often framed. And yet, if you take the same doctor and embed them in an Aledade system, or you put them in a kind of Wild West practice where they don't get any data and they're kind of flying blind, you're going to get very different results. And so it's the systems, that could be our tagline. It's the system, stupid. Right? So, if you get it to work where people want to do the right thing, but the right thing has to be kind of the easy thing. And if you have to be chasing multiple records, there's just a lot of reasons why the accountability journey that we're on still not exactly pointed in the right direction, in my view.
When you started, there was really no formal quality measurement. We counted a couple of years back and we figured out that one physician in an Allidaid contract, happened to be North Carolina that we looked, could have had upwards of 46 quality measures that they were responsible for. And I'm sure you've heard these other statistics. The estimate is that 785 hours per physician and over $15 billion spent annually. Yeah. How did this sort of sorcerer's apprentice level of quality measurement come about?
It's the same problem that we have overall in healthcare. It's fragmentation. It really should be a strategic, smallish number of measures. Although once we get to this promised land where the data flow from the practice and you're able to look at more things, I actually think it can be running in the background. You definitely do not want the practitioners to have to be messing with this. You want them looking at the data, maybe with you or with somebody that then can help figure out how to get the numbers better, not for the individual doctor, but for the group or the plan.
I think you're talking about, there's two burdens in quality reporting, potentially. One is the documentation. And as you said, that's gone a little bit crazy. There's a vision of the future where, as you said, it's automatic. It comes out of whatever electronic health record, and that would be great. But the other is just mind share for the physician. How many things does he or she have to be worried about? And I think there are declining returns at some point of how many things you want them to focus on.
100%. I think the thing is that we throw these responsibilities at physicians, and often they don't have the wherewithal to get the things done unless they're trying to do them themselves. Or they have a practice where they have, some small number of nurses or, aides that are kind of chasing down data and trying to figure out who has to get called in. It is like a sorcerer's apprentice. It's a very good metaphor. So when you have the systems, the kind of systems that you create, that advanced practices have, then the physician it gets teed up perhaps. And they may not even have to see it, because you can have like the person that's checking you in say, I see you're due for a mammogram. Can I make you an appointment, or can I help you with that? So, it's kind of team-based care, automation to the degree that you can possibly get it without interfering with the customer experience or patient experience. And a lot of things going in the background. So the problem is when practices aren't enabled by these kinds of systems, it becomes kind of a nightmare.
Sean once told me a theory, I don't know if he still stands by this, that if somebody working at a health plan is trying to sell their health plan to a Fortune 500 company, saying, use us for your employees. And look, we have 20 quality measures that we use to measure our physicians. And another health plan comes and says, well, we have 30. We measure physicians on 30. And that sounds so great. Who could possibly argue against it? But then I would think that CMS would be a little more sophisticated than that. But they too have gotten into this thing that if it matters, you have to show that it matters by making a quality measure about the thing, even if it's not a good quality measure.
Yeah, no, and I think there's plenty of criticism to be appropriately handed out to us as well. We have some measures that are not that great, and we're in the process of curating. We're curating the HEDIS measures, so we're retiring a number of them.
We've often seen quality measures often as a statement of values that, if we think mental health is important, we have to have a quality measure on it, even if that quality measure mostly takes up physicians' time more than improves clinical care. I just wonder what your thoughts are.
Right on. You're right. I mean, I don't know. We've spent a lot of time trying to get behavioral health measures that really matter. I mean, ultimately, I think we want to know what the outcomes are, honestly, in behavioral health. And, but we also want to know a little bit about the intermediate outcomes. So
the risk of suggesting new measures, I want to talk about some new areas where questions of quality have crept in, telehealth and in-home care, which is, grown significantly since the COVID epidemic. Are these areas that NCQA is interested in?
Interested in, yes. Have we made progress on them? We have a virtual care program that's pretty slow getting started, just to be honest. I think there a lot of customer experience stuff is going to be predominant. How's that working for people? We know it's very popular with patients. Um, I'm very, very interested in the concept of in-home care. I've really been looking at hospital at home, and it just feels like something that's being kept in a small box and not allowed to grow and become what it really should be, which is a model for seamless care, it seems to me. But, let me just go to my major harping point, which is if the payment model doesn't support doing these things, if you lose money when you do things more efficiently and better, it is not going to work. And we have payment models all over the place that are just really counterproductive.
You were talking about systems matter. The phrase I use is context
Absolutely.
matters. So I often have people at CMS or on the Hill saying, which payment code in the fee schedule is the most value-based? And I was like, context matters. If you're doing chronic care management in a fee-for-service environment, you're not going to get great outcomes. But you can do that in an accountable context, and it could be a really useful tool.
Let me just bring up something that as we think about measures that are troubled measures, let's say, we've got a measure, I don't remember what it's called. It's called coordination of care, which is a very generic title, but it's really about what is happening when the patient is discharged from the hospital, and is there a plan, and is there kind of the follow through happening? And I'm listening to my staff tell me this is not a good measure because nobody has the data. And because nobody has the data, it's kind of impossible to do the job right. So it's beyond a measurement issue, is what I'm trying to say. So maybe if it's an ACO that's a hospital-based ACO and it's really committed to the model, which is a lot of ifs, maybe it's possible to have it work out. But overall, this is one of the most fraught moments, right, in the patient's journey, one of the most high risk, and the danger of patients crashing and either being readmitted or worse at the time of discharge is huge. So I think we have to go after some of these impediments to measurement, which really are impediments to doing the job right.
In that area, Ality internally has a measure that we use and a lot of people use, which is just the readmission rates, because the readmission rate is capturing whether the transition and coordination of care happen.
Right.
In quality measurement, one of the things that I have always liked about an organization like an accountable care organization, that the best rewards happen when you lower healthcare costs by keeping people out of the hospital. It's a great outcome measure. In the HEDIS measure set, I'm not asking you for exact number, but what's the ratio of sort of process measures to outcome measures? And do you think it's good enough right now?
I actually think it's really important. We're all learning how to do systematic care in a good way. And you all, I think, are at the front of that curve, but there are plenty of people who really don't know how to do it. And a lot of our standards are really kind of the process steps that are necessary to get to the good outcome. There are also, outcome measurement is a tricky business if you're going to do it fairly, because we know that many outcomes are driven by factors beyond the control of healthcare. There are social determinants. There are things like somebody has a wife at home and the wife takes care of them. That's a different situation than somebody that lives by themselves, somebody that's in an unstable housing situation, and so on. So I think we need more, but I always think it's kind of, you want the anchor of the outcome measure, but the accountability perhaps should be for related process measures.
I mean, I'll quote my co-host one more time, where he had said that you can have a system that is simple or fair, but not both. That it gets complicated, and so you're right on both sides. It's really hard to get it just right.
Yeah, there are a lot of reasons why I think we want to use outcome measures judiciously to kind of make them the true north of the system. I'm one of the issues that I'm really electrified by, I guess is the word I want to say, is how many patients that have hypertension or diabetes go on to kidney failure. And we've just done a series of meetings with the American Heart Association, the American Diabetes, and the Kidney Foundation, who have a big project with their registries to try to really more aggressively manage these conditions to bend the curve on the progression to renal disease. But in these meetings, it's very interesting because these are often academic physicians who say, well, I can't take care of all that. And again, it just makes the point that it's a system that's going to be able to, bend that curve, not the individual doctor trying to figure out how do I get this person who lives in a food desert to get a healthy diet. So those are the kinds of things that I feel like we're ready to embrace. That's why I'm not ready to say we have too many quality measures. We have too many low quality measures, low quality measures. And that includes us. So we need to get rid of those and bring in the ones that really matter.
One of the areas, and this is a CMS issue, not an NCQA issue, but as you discuss process versus outcomes, it occurs to me, CMS adopted some process measures on medication adherence for hypertensive patients and for diabetic patients at a time when that was cutting edge and we didn't have outcomes measures or access to those data. But the STARS program now measures both. It measures the process measure and the outcome measure. And the outcome measure is better and they don't correlate well. And I think it's an area where oftentimes we do process because we don't have outcomes measures, but now that we have an outcome measure, CMS should abandon the process measure.
Absolutely, 100% agree. As we were evolving our accreditation program, when we started out, we had all these standards for prevention, like you need to educate your physicians about what your standards are and, start quality improvement. Once we have the HEDIS measures for prevention, we abolished those standards. And those standards are kind of process standards. So we wish we had more. We have them where we think it's appropriate to have them. So we were very early with outcome measures for blood pressure control, for example. And but there's always a lot of arguing going on about where does that belong. And that's another thing, is that the one size fits all paradigm, we want to get to a place where there's much more customizable quality measures.
And just to keep going on Sean's point, and the answer may just be politics, but why are there these medication adherence measures? Now, I want to be clear. I know these are not NCQA's measures, like measuring whether a patient's diabetes is under control and also whether their blood pressure is under control are triple weighted in Medicare Advantage. So there were 3 times the other measures. And we would say, make them 5 times, make them 6 times weighted. Stop measuring us on whether the patients take their diabetes medicine or their hypertension medicine. Just
no argument from me, Josh.
And do you have a sense why those measures linger?
I think it has to do with Part D.
I think that's right. I think the outcome measures on one side and medication adherence are on the other side.
Yeah.
But why do we have to have these Part D measures?
Because some people buy Part D plans as standalone.
So Peggy, you've talked about health plans being more responsible for the measures, or health systems rather than individual clinicians having to take time to attend to these. Is the solution to that better digital quality measurement? And if so, how do we get there without just a massive amount of resources to get us there?
Yeah. First of all, I think the people that are delivering the care are really at the front lines of doing better with quality and so on. They are in the position where they can see what they're doing, hopefully, in the future. We started out digitalizing quality measures in order to lessen potentially the burden. We figured, naively, this data can just flow out of the data systems and then the practitioner can be set free. But actually, I've come to really believe that it's the digital enablement of care that's going to make the big difference. That's in many ways, both, there are things that we could be doing with wearables, I think, where I feel like the agenda is not really going anywhere at the moment. But, having the physician have the information they need at the point of care, very important. But the hospital at home, to me, really is an example of how care could work. For example, for frail elders over a whole spectrum of their care journey, not just the hospitalization. And I realized that the hospital at home is not being built to its fullest potential, and it's used mostly for CHF, as far as I can tell, congestive heart failure. But if you think about a frail person, there are ways of having monitoring going on, not at the same level as hospital, but where you can kind of anticipate when somebody is going downhill, and it doesn't require them to show up at the emergency room to kind of make sure they're getting what they need. So to me, like the whole post-acute, for example, situation, which is so fraught and so full of risk for people, using some of that technology, and it has to be adaptable to go up and down, because you don't want to waste money doing all kinds of observation of things that are kind of not needing to be observed. So I think it's a huge challenge for the system to design itself like that. And that to me is going to not happen at the plan level, and probably not at the primary care level, probably more at the ACO level.
Peggy, back in the mid-90s, I worked for the state of Maryland, and it was part of the commission that set hospital rates. So it's a way we controlled hospital costs, but also tried to spread social costs like uncompensated care. And at one point, the hospital industry came to us and said, "You're setting our rates without any reference at all to the quality of care we provide." And it just boggled my mind at the time. We were like, oh my God, how would we even begin to measure quality of care? And would we give more money to low quality hospitals or to the high quality hospitals?
Oh, well, there's an answer for that.
Yes. I worked with some economists who answered that question for me. But I just wanted to point out that thanks to you and the 35 years you've dedicated to this issue, probably more, it's now inconceivable not to include important quality considerations into all these financial conversations. And in fact, maybe they should be given greater weight than some of the financial considerations. So I want to thank you for all the work you've done, and thank you for your time here with us today.
I enjoyed it. It was really fun. And congratulations to you on the great work you're doing to get primary care to be what it really is meant to be, and to make people want to do primary care. I think we've been very good at giving primary care a lot of assignments and not the resources to get them done.
Amen.
All right. Thank you, Peggy.
Thank you.